Hello everybody and welcome to our module on blood groups. Red blood cells contain certain antigens which can drive the formation of antibodies, and a person's blood group is defined by the red blood cell antigens found on their particular red cells. And it's very important to know a person's blood group in order to safely administer blood transfusions. You need to match the transfusion to the patient's blood type. If you administer the wrong blood type, dangerous consequences can occur, as we'll talk about in this module. And there are two major blood grouping systems. The first one is called the ABO system, and the second one is called the RH system. Let's begin with the ABO blood grouping system. The A and B antigens are two antigens that can be found on red blood cells. Now, if you have the A or B antigen on your red blood cells, you will not develop antibodies against these antigens. If you did, that would lead to autoimmune destruction of the red cells. However, patients who lack the A or B antigens do generate antibodies against these antigens, and this has important consequences when you want to transfuse blood from another person. The antibodies against A and B appear in the blood by about 4 to 6 months of age. The reason they appear is because exposure to bacterial antigens with a similar structure drives formation of antibodies against the A and B antigens, and this occurs in babies as the gut becomes colonized. The antibodies against the A and B antigens are IgM, so they do not cross the placenta. This means that if the baby has a different blood type from the mother, that will not be a problem in terms of these antibodies. And a key point is that the A and B antibodies are naturally occurring. They occur in response to bacterial antigens, and this is in contrast with some other antibodies that we'll talk about later to other red blood cell antigens. This slide shows the four blood groups that are possible via the ABO system. If you are blood group A, this means you have the A antigen on your surface, and you will have anti-B antibodies in your plasma because you lack the B antigen. If you are blood group B, it means you have the B antigen on your surface, and you will have anti-A antibodies in your plasma because you lack the A antigen. Patients who are AB have both the A and the B antigen on their surface, so they will form no antibodies in the plasma. And finally, patients who are group O have neither the A nor the B antigen on their surface, and therefore they form antibodies against both A and B antigens. The ABO antigens are made up of different combinations of 4 sugar molecules. The 4 sugar molecules are galactose, an unusual sugar called fucose, and 2 other sugars called N-acetylgalactosamine and N-acetylglucosamine. All red blood cells, even those of patients who are type O, have this common basic structure on their surface. This is called the H antigen. It consists of 2 galactose molecules, a fructose, and an N-acetylglucosamine. If the H antigen is left unmodified, then the patient is type O. If the H antigen is modified by addition of an N-acetylgalactosamine molecule, then the antigen becomes an A antigen. If the H antigen is modified by addition of a galactose molecule, then the antigen becomes a B antigen, and patients who are AB have both of these modifications present on their H antigens. Now let's talk about the RH blood group system. This is the most important blood group system after ABO. There are more than 50 antigens that are part of the RH system, and they're all named for letters following A and B, letters like C, D, and E. And in contrast to the sugars that made up the AB antigens, all of the RH antigens are transmembrane proteins. Of the multiple Rh antigens, the presence or absence of the D antigen is critical, and that's because the D antigen is highly immunogenic. You will often hear patients referred to as Rh positive or Rh negative, and what this means is if they're Rh positive, they have the D antigen of the Rh system. If they're Rh negative, they lack the D antigen of the Rh system. The other Rh antigens are not routinely tested, ones like C and E. Most of us are Rh positive. Rh positivity is very common among Caucasians. 83% of people are Rh positive. In some Asian populations, 98% of people are Rh positive. If you are Rh negative, however, you can develop anti-D antibodies, but this does not occur naturally like it does with the A and the B antigens. The only way to develop anti-D antibodies is if you are exposed somehow to D positive red blood cells. And 2 ways this commonly occurs is through a blood transfusion from a D positive donor to a D negative recipient, or via pregnancy. If the mom is D negative and her baby is D positive, the mother can develop antibodies. The antibodies against the D antigen are IgG. This means that they are a problem in pregnancy because they can cross the placenta. And for this reason, the Rh system is very important in pregnancy, and if you have a mismatch between the mother and the baby, it can be a big problem. Newborn hemolytic disease occurs when antibodies from the mother cross the placenta and attack the red blood cells of the baby. This is classically caused by anti-D or anti-Rh antibodies in the mother attacking the baby's red blood cells, although it is reported with other antigens other than the D antigen. This can only occur in terms of the D antigen if the mother is D negative and her baby is D positive because of genes inherited from the father. A D negative mother is capable of developing anti-D antibodies, so if the father is D positive, the baby can also be D positive. The way the antibodies develop is that during the first pregnancy of a D negative mother with a D positive baby, the mother is exposed to the D antigen on the baby's red blood cells at the time of delivery. At delivery, there is some mixing of the baby's red cells with the maternal system, and this can expose the mother to the D antigen and stimulate an immune response. From that point forward, the mother will have anti-D IgG antibodies. If she becomes pregnant again, the anti-D IgG antibodies in the mother can cross the placenta because they are IgG and go to the fetus. If the second baby is also D positive, this can lead to hemolysis in the baby that will occur in utero, and that will result in newborn hemolytic disease. If the antibody titer in the mother is low, it will be a mild case which can present as hemolytic anemia in the baby. If the antibody titer in the mother is high, it can present as what's known as hydrops fetalis. This is the syndrome that occurs when babies have massive hemolysis. You can also see it in certain severe forms of thalassemia. The baby develops massive edema, that's why it's called hydrops. You can see this on ultrasound of babies who have this condition. There will be pleural effusions, pericardial effusions, ascites. The mechanisms of the edema formation include high output congestive heart failure from the anemia. In addition, there is lots of red blood cell production outside of the bone marrow in the spleen and liver. This can lead to obstruction of flow through those organs. This can lead to portal hypertension. So by all of these mechanisms, you get fluid accumulation in many of the cavities in the fetus. And like I said before, this is also seen in other severe anemias of newborns, especially hemoglobin Bart's, which is a severe form of alpha thalassemia. Newborn hemolytic disease can be a life-threatening condition, so the key is to prevent the formation of the anti-D antibodies in the first place among women who are D negative. The way this is done is by giving D negative mothers a substance called anti-D immune globulin. It also goes by the name of RhoGAM. This consists of IgG antibodies to the D antigen. If any D positive red cells from the fetus get into the maternal circulation, these antibodies will coat that red blood cell, and that will lead to rapid macrophage clearance before an immune response can occur. This is given in the third trimester to women who are D negative to prepare them for delivery, and it blocks and prevents isoimmunization at the time of delivery. You can screen mothers who are D negative for antibodies to the D antigen using the indirect Coombs test. Recall that in the indirect Coombs test, you begin with the patient's serum, in this case the mother's serum, and you mix that with red blood cells, and in this case it's mixed with red blood cells that are D positive. If the mother's serum and the red cells swim around happily together with no interaction, this is a negative test, and it means there are no antibodies in the maternal serum to D positive red blood cells. On the other hand, if the red blood cells agglutinate, this means it's a positive test, and the mother does have antibodies in the serum to D positive red blood cells. This is called isoimmunization. There are other antigens besides the ABO and Rh, but they are not routinely tested. These go by different names like the K antigen, the Lewis antigen, the Duffy antigen. You can read about many of these different red blood cell antigens. These antigens are only tested for when the patient has an abnormal screening test we'll talk about in a minute. And the only way you're going to develop antibodies to any of these antigens is from a prior pregnancy or a transfusion. None of these occur naturally. The only antibodies that are naturally occurring are to the A and B antigens. Now let's talk about transfusion medicine, and let's go through some of the common tests that are performed in order to safely transfuse blood. First of all, you need to determine the patient's blood type, and this is usually done together with another test. When we order a type and screen, we determine the patient's blood type in terms of A, B, and Rh antigens, and we also perform an antibody screening test for antibodies to more rare antigens, and then we only do further testing if the antibody screen is positive. If you order a type and cross match, often called a type and cross, this involves matching of the donor blood to the patient. We'll talk more about what that means in a minute. So the way you determine a patient's blood type is by taking the patient's red blood cells plus antibodies like anti-A, anti-B, or anti-D, and seeing if agglutination occurs. If it does, that indicates the presence of an antigen. So for example, you could take the patient's red blood cells and mix it with anti-A antibodies. If they float around happily together, this means the patient is A negative. On the other hand, if the red blood cells agglutinate, this means that the patient is A positive. And you can do the same type of testing for the B antigen and for the D antigen. Once you know the patient's blood type, you can do a screen for other antibodies to more rare red blood cell antigens. This involves taking the recipient's serum and adding it to standard red blood cells that contain many different red blood cell antigens. This will screen for any antibodies to those rare red blood cell antigens. Patients will only have antibodies to these antigens if they've had a prior exposure, for example, from previous transfusions or a pregnancy. There are special red blood cells called reagent red blood cells used for this test. They contain many red blood cell antigens. If there is no agglutination, it means the patient lacks any significant antibodies. If there is agglutination, it means the patient has some antibodies to less common antigens present, and you do further testing to figure out exactly which antibodies are in the serum. Here's a depiction of how the antibody screen is performed. You begin with the recipient's serum and you mix that serum with standard red blood cells that contain many different red blood cell antigens. If there is no agglutination, that's a negative test. It means there are no important antibodies in the recipient's serum. If the red blood cells agglutinate, it means there are antibodies in the serum to some of the more rare red blood cell antigens. You can then do further testing to figure out exactly which antibodies are present. When patients have an abnormal screen, you next determine which antibody is present by testing the patient's serum against a large panel of antigens. Once you figure out which antigens are the problem for that particular patient, in subsequent transfusions, you test the donor blood for presence of that antigen. This can be challenging in patients who have a long transfusion history. So, for example, patients with sickle cell anemia or beta thalassemia major receive many transfusions over the course of their lives. As a result, they can develop many antibodies to minor antigens. So a key point is that you shouldn't transfuse patients unless absolutely necessary. The more you transfuse them, the more you increase the likelihood that it will be harder to find a match down the road. The type and cross match is another variation of the indirect Coombs test, where you start with the patient's serum and mix it with red blood cells. In this case, the red blood cells are potential donor red blood cells. This is the final test of a product to be transfused. So you begin with the recipient's serum, you take donor red blood cells of the same blood type that you're planning to transfuse. If you have a negative test with no agglutination, that indicates there is no problem mixing blood from this donor with that recipient. A positive test indicates that there is some antibody in the recipient's serum that does not like the donor red blood cells. Let's talk about some of the blood products that can be given to patients. Packed red blood cells are red blood cells with the plasma removed. They are usually administered instead of whole blood because it minimizes the volume given to the patient and allows the blood product to be infused over a shorter period of time. Platelets can be administered to patients who have a very low platelet count. Platelets do express the ABO and HLA class 1 antigens. They do not express the RH antigens or HLA class 2 antigens. Attempts are made to appropriately match platelets to donors. However, reactions from mismatch are less common than with red blood cells, so sometimes mismatched platelets are administered if there's a short supply. Fresh frozen plasma, or FFP, is administered to correct deficiencies of clotting factors. FFP is plasma after removal of red cells, white cells, and platelets. It's frozen for storage. That's how it gets its name. Once it's thawed, it must be used within 24 hours or the clotting factors degrade. And it will correct a deficiency of any clotting factor so that the PT and PTT, if they are prolonged, will normalize once you give an infusion. Cryoprecipitate is the precipitate that forms when FFP is thawed. It contains lots of fibrinogen, so it's given in massive bleeding disorders, especially after trauma, when fibrinogen is being consumed on a large-scale basis. It's also given in rare disorders where there are low fibrinogen levels. I'll finish by talking about some of the reactions patients can have to transfusion. We'll talk about acute hemolysis, anaphylaxis, febrile reactions, and TRALI. You should know there are many other potential reactions to transfusions other than these ones here that I'll go through in the next few slides. Patients can develop heart failure after blood transfusions. Rarely, patients can develop sepsis if there is bacterial contamination of the blood products, and there are many, many other potential reactions. Acute hemolytic transfusion reaction is the feared complication of blood transfusions. This is the reason that we do all the type and cross-matching that we do in order to prevent this from occurring. This is when there are preformed antibodies in the recipient against the donor red blood cells. It's an example of a type 2 hypersensitivity reaction, and this usually happens if a patient is accidentally transfused with the incorrect blood product. This is a life-threatening reaction caused by acute hemolysis of the transfused red blood cells. It can be intravascular hemolysis if complement is activated. If anti-AB antibodies, which are IgM, attack the donor red blood cells, they are potent complement activators, and this can lead to intravascular hemolysis. In addition, there can be extravascular hemolysis if the spleen clears red blood cells coated with antibodies. It can lead to disseminated intravascular coagulation. This can present with fever and chills and flank pain. There can also be oozing bleeding from intravascular sites if the DIC has caused a coagulopathy. There can also be evidence of hemolysis like jaundice and elevated bilirubin and dark urine. And if you perform the direct antiglobulin or Coombs test, this will be positive. This is a test for antibodies coating red blood cells, and there are antibodies coating red blood cells in this disorder. As I said before, the usual cause is transfusion of the wrong blood product, and this usually happens because of a system or clerical error. And hospitals employ numerous safety measures to prevent this. The blood type has to be checked, an antibody screen and cross-match is done. There is very careful identification of the patient and the unit of blood being transfused to make sure that this does not happen. Rarely, patients can develop anaphylaxis to a blood transfusion. This is obviously an allergic reaction, just like all forms of anaphylaxis. It is a type 1 hypersensitivity reaction. Patients will develop hives and angioedema and wheezing and hypotension. One place where this classically occurs is among individuals who are IgA deficient. They can produce anti-IgA antibodies because they are IgA deficient. These can react with IgA that is sometimes found in the transfused product. This can also occur if the patient has a reaction to plasma proteins that are in the transfused product. The treatment is to stop the transfusion, obviously, and then administer standard anaphylaxis therapies like epinephrine and antihistamines. A febrile non-hemolytic transfusion reaction is the development of fever and chills with no other systemic symptoms among patients receiving blood. This is caused by cytokines in the blood product, especially IL-1. These are generated by white blood cells in the blood product during storage, and they accumulate in stored blood components. Sometimes blood undergoes what's known as leukoreduction to eliminate white blood cells and try to eliminate the frequency with which this complication occurs. TRALI is transfusion-related acute lung injury. This is the sudden onset of hypoxemia during transfusion. It is an inflammatory reaction in the lungs. Fever and chills are common. If you perform an X-ray, you will see infiltrates on the chest X-ray, and this results from neutrophil activation by blood products. Some patients, for reasons that are not entirely understood, are predisposed with neutrophils in their lungs. The neutrophils release cytokines and reactive oxygen species and enzymes when exposed to the blood product. These damage the pulmonary capillary endothelium and lead to exudative fluid loss and pulmonary edema. That's what generates the infiltrates on chest X-ray. I'll finish this module by discussing the response you should have to any suspected transfusion reaction, and that is to stop the transfusion. This is a classic question on clinical rotations, asking medical students what to do if the patient develops a fever or shortness of breath or some other worrisome sign or symptom during a blood transfusion. Sometimes medical students will answer by saying they want to order a chest X-ray or do a complex workup, but the answer is always to stop the transfusion right away, and then you can do all the diagnostic testing. And that concludes our module on blood groups.